When we think of disability, at least in our everyday thoughts, we tend to associate it with failure, with dependency, and with not being able to do things. We feel sorry for disabled people because we think it must be miserable to be disabled. But that might be wrong. It's sometimes called the disability paradox. Surveys reveal people with disabilities consistently report a quality of life as good as, or sometimes even better than, the lives of non-disabled persons. Impairment usually makes little difference in the quality of life. There is research, for example, that shows that the overall levels of life satisfaction for people with such serious injuries as spinal cord injuries are not affected by their physical ability. Even the clinical facts of whether their spinal lesion is high or low, complete or incomplete, all aspects that affect functioning don't seem to make much of a difference. Human flourishing is possible even if you lack a major sense like sight, or you can't walk, or you're totally physically dependent on others. So this brief talk will be about ableism and discrimination that results from disabilities, both physical and emotional. Persons who are differently abled based on physical or mental issues suffer from discrimination in society in a lot of different ways. This oppression is experienced on a day-to-day basis, and it adds to the problems and discomforts that these individuals face. Some of the social issues that arise include isolation, unemployment, educational problems, discrimination, neglect, abuse, and institutionalization. If the individual is a member of a minority group as well, intersectionality comes into play and further complicates their lives. Add to that a family system which may or not be supportive, the person's own character and personality, the age of onset, and other factors all create variables in how this disability is experienced. But the core of oppression comes from cultural and social beliefs about disabilities. The environment can be more or less abling depending upon these factors. A few very basic definitions here. Functional disability is something you'll hear about from time to time when working with disabled individuals or sometimes elderly individuals as well. And functional disability represents the actual physical ramifications of the disability itself, that is, the limitations which result from that person's condition. The socially imposed disability, however, arises from the perception of the person's abilities or disabilities, and this results from the interaction with the social environment in large part. It is very structural in nature. We tend to view disabled persons with negative stereotypes that result in those persons feeling more isolated and marginalized than would be necessary, really, and as a result, they feel like they're worth less. And the degree of disability that this person feels then may be more related to the social environment than to the functional disability itself. When not handled properly by those around the disabled person, the disability can thus impair the person much more traumatically and pervasively than is necessary. If you look at the historical perspective on physical and mental disabilities, the meaning of these conditions has evolved throughout this history. The Elizabethan Poor Laws of 1602 identified those with physical disabilities as a part of the deserving poor and put a focus on the need for these individuals to have charity. And while this was benevolent in its enactment, nonetheless it tended to compound the stigma that was associated with the disability. In the early 1800s, Dorothea Dix, you may remember, advocated for improved services for the mentally ill. Prior to that time, the mentally ill and the physically disabled were often housed in almshouses, along with other individuals that were criminal in nature, for instance, and many of those almshouses were in deplorable shape. While Congress passed legislation that granted funds for improved services for the mentally ill, it was vetoed by President Pierce, who believed that the federal government did not have a role in providing for the social welfare of its citizens. During the 1800s, scientific knowledge began to flourish, and there was a desire to apply the scientific method to human beings and the human condition as a way to understand what motivated individuals. Social Darwinism resulted from this. In the early 1900s, a variation on this, eugenics, which was a science that was intended to improve the genetics of the human race, led to a view of the disabled as an unproductive, unfit, worthless group of people. Out of this, attempts to control their reproduction, for instance, was developed, and many were institutionalized in very terrible conditions. The result was that they were separated from the larger population during this time. Surgery, bloodletting, asylums, isolation, shock therapies for the treatment of mental illness in the 1800s and early 1900s eventually gave way to psychotherapy as that science emerged as a way to deal with problems, and pharmacology in the 1940s and the 1950s. In fact, after the World Wars, a more humanistic view of disabilities developed as so many disabled veterans returned from war and had great needs that society needed to tend to. By the end of the last century, strides were being made to mainstream the physically and mentally disabled in schools and in communities as a whole, and to break down barriers to access. Institutions were closed, and professionals put their focus much more upon community engagement and community treatment methods. The Americans with Disability Act of 1990 also paved the way for improved conditions for disabled individuals as well. First, we'll take a look at some of the concepts associated with mental and emotional disabilities. A psychologist by the name of Theodore Sarbin referred to the transformation of social identity that takes place when a person is defined as mentally ill and is admitted to a mental hospital. The person's diagnosis in and of itself is pejorative and is degrading to the individual in a public sense. People begin to lose their belief that the individual is competent. And this gives the person the basis for self-devaluation. The person becomes labeled as a mental patient and undergoes a transformation of social identity as a result. Persons begin to deal with that person as a mental patient, and eventually the person accepts that label. I worked with a young man in my master's level field placement in a psychiatric hospital, and one of the goals of the psychiatric treatment team was for him to accept his diagnosis of schizophrenia. He vigorously opposed that and didn't believe that he was schizophrenic, and his mere refusal to accept the label and to see himself that way kept him in treatment quite a bit longer than he probably needed to be. Having come from an environment where I worked with children and adolescents who were sent through the juvenile court system as an alternative to the psychiatric system, his behaviors were not much different from those kids that were being treated in behavioral treatment programs in the community. This is a good example, I believe, of the focus upon the label and what that can do to the individual. Sarbin also noted that social pathology tends to be diagnosed the most frequently among populations with predominantly ascribed statuses, such as the poor and the minorities. These persons who are most bound to these ascribed statuses and granted roles which they are compelled to enact are the ones who should have our most focused attention in social work. Irving Goffman was a famous sociologist in the 20th century who wrote about the conversion of the individual to a patient identity. In the process of becoming a mental patient, Goffman believed, the person's life history is revised in light of the current psychiatric diagnosis. While the professionals gather the history from the patient, mental health staff look back through the patient's life for those early symptoms of the mental disorder in that patient's past and trace them forward then from the patient's early years to the present. In order to make sense of the current situation, Goffman said the patient then has to rethink all of his or her past life as that of being a pre-patient with a mental illness gradually progressing and developing over the years. David Rosenhan wrote an article in the 1970s called On Being Sane in Insane Places. If you're not familiar with that article, as you take more classes with me in the next few semesters, you'll be reading it then, but he writes about this search for clues in patients' lives for what led to the current illness. Interestingly, many of the patients whose history was being reconstructed by the mental health staff were pseudo-patients. They weren't real. It's a very interesting article. But getting back to Goffman, he believed that the routines of the hospital setting prescribe that the patient accept a deviant role. They go through what he referred to as mortification and a stripping when entering the mental hospital. Mental hospitals, much like convents and monasteries and prisons, are what are known as total institutions. That is, where the individual in that institution has to give up all of their identity and accept a new identity that's given to them by the persons in control of the institution. How patients are expected to behave in such a setting as the mental hospital creates many of the symptoms that are associated with the mental illness, creates the symptoms itself. The young man that I was referring to a few moments ago, in his refusal to accept the schizophrenic diagnosis, became very angry and began to act out violently. And this was attributed to his illness, even though it marked a frustration on his part, I believe, more than anything else, for his view of the world not being accepted. Eventually, a good mental patient is going to accept the role that's assigned to him or her and become stigmatized in his or her own minds and again in the minds of others around them. And so the illness then becomes chronic. Thomas Szasz wrote a book called The Myth of Mental Illness in the 1970s, or probably the 1960s actually. And his theory was that mental illness is neither mental nor an illness. He believed that the concept of mental illness was a myth, that it was not a medical condition, but was a metaphor for abnormal behavior. The abnormal behavior is interpreted as if a person has an illness in the mind, and eventually, he said, the as-if part of that interpretation is dropped as it is used over and over and over again, and the mental illness then becomes a reality. This illness of the mind becomes real. Szasz said he believed that mental illness is not an illness, it's deviant behavior, and that good mental health is primarily a person making good choices in life and nothing more than that. He believed that the notion of mental illness excuses the individual from responsibility for behaviors that that person exhibits, and also subjugates the person to a mental health or medical professional and aids the mental health and medical industry. Townsend wrote and believed that the initial recognition threshold for mental illness in most communities is pretty high, but a pre-patient's symptoms are denied and normalized by the community until some last straw is reached. And once the person is recognized and labeled as mentally ill, the recognition threshold for symptoms drops drastically, and acts which had previously been seen as neutral or perhaps troubling all of a sudden now become psychiatric symptoms. Townsend's really pointing to the important role that interpretations place upon the assignment of diagnoses and labels in the mental health industry. Interestingly, he says, unlike in communities, the initial recognition threshold among mental health professionals tends to be low. Townsend is talking to you and me here, so it's important to hear this. In fact, the author of another book on diversity, George Appleby, and his associates point out that mental health professionals frequently have difficulty recognizing anybody as completely normal. Do you have any friends that are in the field that when you talk with them, they're always diagnosing people around them? This is an early sign of this problem, I believe. Clinical experts attribute the social isolation that these people experience to the nature of the disability itself. This is certainly up for disputation. When the disorders may indeed have significant problems and cause significant damage in a person's life, but many of the obstacles that these individuals face have more to do with how the community responds to them rather than anything to do with the disability itself. Physical disabilities have another perspective to look at here, and they have a different impact and intervention implications depending upon when the disability is first discovered, and we have it separated here into early and later onset. I'm sure there are much more complicated and more thorough assessments of how to go about viewing disabilities, but for the purposes of this talk, this will suffice. With an early onset physical disability, a lot of times what you see is you have the parent responding in ways that are very difficult for the worker to treat. The parent's response, in fact, is very key to how the child develops. The parents may go through a mourning process and experience a sense of guilt if the disability is congenital. Sometimes this mourning translates into anger directed towards the individuals around the child who are unable to do anything to alleviate the disability. And so sometimes you'll find the parents of disabled children to be very difficult to work with for this reason. But understand the anger arises from the sense of grief that they're dealing with as they recognize that their dreams of raising a fully functioning child are being dashed. The disabled person might experience isolation and oppression, and this can be a problem for the whole family system as they try to clear the way for this young person. The responses of the family system and the responses of the individual really have options. How is it viewed by the family and by the individual? Is it viewed as a challenge, as a loss, or as a threat? And framing it as a challenge, this theory suggests, is more likely to have positive results. And when you're working with a family and the individual, this might be an approach that's useful to take. The earlier the intervention, the more progress is likely to be made in the child's development, and the greater compensation in functional abilities can be made in areas that relate to the child's disability. If the focus primarily remains upon the impairing nature of the disability, however, this is likely to affect the child's development in a similar way. Now, if we have a situation with a later onset of disabilities, then the implications for the person are different, as the person has had the experience of normal functioning to compare the disability to. This person may very well suffer a loss of identity for a period of time related to the loss of capabilities and roles, maybe losing career, relationships, and so on. And the client is likely to go through a period of mourning for their loss. This is certainly to be understood as very normal in this process. Sometimes there is physical pain associated with this disability, and this, of course, is true for early onset disabilities as well. And this pain can cause additional problems that need to be assessed and monitored as well. In recent times, there's been more of a focus upon the concerns with the use of medications for pain management and the other types of problems with addiction that can develop from that. And so this is something for the worker and the client as well to monitor closely. The personality of this individual and the individual's perspective will be a large factor in how he or she is going to deal with the disability. Again, is it seen as a challenge, a loss, or a threat? Our society has placed a value upon physical appearance and perfection and beauty. That's the American ideal, and on one's ability to be very physical and to perform. And so all of these kinds of American values also contribute to the difficulties that the individual has to integrate and deal with in learning to live with his or her disability. Now, for those with a mental illness, social stigma, demoralization, poverty, rejection, unemployment, and also perhaps difficulties in accessing reciprocal relationships with peers all contribute to social problems. To a certain extent, this also applies for those with physical disabilities as well. Early interventions are more likely to enable persons with mental illness diagnoses to maintain higher levels of functioning and to repair their self-esteem and self-confidence, and thus to be more productive in the community around them. These persons can be encouraged to continue with their education and maintain their employment and take care of their meaningful relationships and live independently. This serves to decrease the stigma associated with the status of the mentally ill. Although, one thing for the worker to assess is the community in which the individual resides and whether or not it is set up to facilitate this person's integration into the community. There may be some macro level interventions that are necessary on the part of the worker to assist this individual in returning to an independent life. Keep in mind that your first encounter with a client and the early phases of treatment of this person's disabilities are times when a very delicate balance exists in this person's life. For the physically disabled, this may focus upon how they view their disability as a challenge or a loss or a threat. For the mentally ill, it may be whether they're focused upon their mentally ill diagnosis or are they just having problems in living. Their choices here can really tip the balance in how they feel and whether or not they see themselves as more incapacitated or more self-confident and effective. And again, I can't stress enough the significant others around the disabled individuals also need to be worked with and encouraged to have the same proper attitudes regarding those individuals. Mainstreaming, of course, especially since the ADA was implemented in the 1990s, are a solution in many ways for the disabled, giving them interactions with the larger society and reducing isolation and marginalization. But sometimes acceptance is tentative, and mainstreaming can occasionally subject a young person or person who is newly disabled to additional oppression and cause some complications in their adjustment. So again, in the mainstreaming process, it's important to get feedback from the client as to how all that's going for him or her. Decisions about mainstreaming, of course, as most all decisions, should be made on an individual basis. There are, of course, many factors which make the person with a disability more vulnerable. And there's a list here you can see that involving demographics, their age and gender, their culture, their membership in other minority groups, their experience with illness and treatment, any psychological symptoms they have, but also what is the nature of the social support networks around them, what's their coping style, what are their beliefs about the illness and their own capacity to recover. I know a young woman who was a very active adolescent, the youngest of 4 children, the only girl with 3 older brothers who constantly kept her challenged physically throughout her growing up years. The family lived on a farm, and she was very active in running the farm machinery and also very active in her social life. In her senior year in high school, she had a snowboarding accident which severed her spinal cord, and she's been confined to a wheelchair ever since. And while there's been a lot of hope that science might advance to enable her to get on her feet and to walk again, she didn't take much time dwelling on that possibility, but instead turned her focus to how to go about adjusting to life with her new reality. Got a job after graduation working as a teller at a bank and was supporting herself, was soon driving her own car and getting herself around in a wheelchair. Went on to university. During her university years, joined a wheelchair basketball team and has been playing all around the world as a part of a U.S. team in wheelchair basketball while she's working on her doctorate in farming science. She's an amazing person and is a great example of how individuals with life-altering injuries can pick themselves up and move on. Now, her parents continue to pray, I'm sure daily, for an advance in science and a cure for her inability to walk. And perhaps she does that as well. But she has also faced her reality and has continued on with her life. This really points to the need to assess for resilience and other protective factors in a person's environment. Keep in mind to look for the person's abilities while you work with this individual and not focus entirely upon what the person is unable to do. This is true for both physical and mental illnesses. Resilience is going to waver from time to time depending upon setbacks and successes. Nonetheless, the creativity of the person and concern for others, engagement with life are things that should be encouraged because they can have a very positive effect on adjustment. I found a website where an individual was writing about disability, and he indicated that he saw 3 things that were key in resilience. One was adaptation, and this was finding another way to do something. For example, the paralyzed person might wheel rather than walk to places. Coping is when an individual gradually redefines his or her expectations about functioning. Making a decision to stroll a half a mile rather than doing a 10-mile run and being satisfied with that half-mile stroll is a coping mechanism that can be very successful. Accommodation is when someone learns to value other things, deciding, for instance, that rather than going for walks in the country with friends, it's more important to be able to go to great restaurants with them. These are the kinds of things that individuals can do to adapt to their circumstances. This teaches us an important lesson that human beings are capable of adapting to almost any situation, finding satisfaction in the smaller things they can achieve, and deriving happiness from the relationships with family and friends, even in the absence of other triumphs. And the social worker must continue to intervene on this multidimensional level as well, as in all situations involving diversity issues, must also be engaged in a socio-political level through roles of advocacy and education. Both micro and macro level interventions are crucial in the treatment of individuals with physical and mental disabilities and are areas where you as a social worker can have an impact. Thank you.